Good afternoon, everyone. Please take a seat, grab some sandwiches and snacks. We're about to begin.
Unanjananku, nalku menarlo yarta matanyarni, yarlo matanyarni, kawi matanyarni, ngair matanyarni, burungalo kangalangalana. From the dream time, our people became the custodians for the land, sea, water and skies. We are still the carers. Yanti yartanga tupatola didi, koma yanti yartalo purna yungandi. This country where everything has a spirit gives us life. Dolaro ngalo tirapendi, koma mikarayapendi, ngalo barna tapema. The spirits will protect and guide us as long as we acknowledge them. Munatindo danko algo tapo por la vierne chiyarte chedonda kangati. From the first son, our way of life has always been to care for the health of people and of country. We are the custodians of Ghana land. Its health is the responsibility of all of us.
And I'm sure you'll agree that that is an absolutely beautiful video of all of the beautiful lands that we are meeting on today, with the original custodians being the Ghana people. So I'd like to pay my respects to the elders past and present. And we also acknowledge the deep feelings of attachment and relationship of the Ghana people to their place, and we pay our respects to the Ghana ancestors and the living Ghana people that are here today. And I'd also like to say vote yes for the Voice in Parliament in October. So welcome. We are celebrating today, and we have absolutely, they call it a showcase, but I'd like to say a rising star studded showcase of the brilliant team from the CHAP project to present the outcomes to you today. Just as a quick word, we are still working furiously on our clinical outcomes and health economic outcomes. So the conclusion ceremony or showcase that we're having today won't be associated with media until perhaps August, when we've got solid scientific foundations to announce. So that's an important thing to note. This is this afternoon's program. We'll be talking to our Chief Consumer, Clayton and Etta, in a few minutes from the Barossa Valley. We're going to present to you an amazing showcase of outcomes from the project, from our sub-projects. We'll also have a little panel to talk about lessons learned. I think there's, with any translation project, with any clinical trials project, there's always lessons to be learned, and then some reflections and closing comments. So I hope you enjoy this afternoon, and thank you all for coming. It's fantastic to see such a terrific turnout from everyone. So thank you to all the people involved in this project. A sincere thank you, including our research team, our partners, our consumers, the project team, the governance committee members who we've just thanked prior to this presentation. Without your support, this project would not have been successful. And I'll mention the pandemic as little as possible, but of course, all of this has occurred during a pandemic period. And so that, I think, just adds even more astonishment to the outcomes that we've achieved from the CHAP project. Of course, I must acknowledge our amazing partners. One of the things that the reviewers of the grant pointed out was the highly representative, highly influential group of partners that we gathered together to be part of the CHAP project. So, and we particularly want to acknowledge Novartis, who are sponsoring our event today. So thanks, Rachel, for your support. The other thing that was part of the feedback was our chief investigators. So they all used to live in South Australia at the time of this slide, but we've had a few move to different appointments since then, notably Steve and Derek and Alex. But the most important thing about our chief investigators that they were highly representative of our whole state across all of the jurisdictions and across the local health network, and that made us particularly strong for our application. Of course, we also had fantastic associate investigators, Billy, who's here today with his laptop up, banging away on the health economics outcomes. So keep up the good work, Billy. We need that in the next few weeks. And Rosanna, who's particularly interested in cardiovascular women's outcomes, and we've now got a stroke project, a secondary project around that. Wendy, of course, Wendy's been there way from the beginning. So, and the Heart Foundation's here today. So, thank you to the Heart Foundation for their amazing support. I think we were one of the last PEG grants. So, thanks for backing us. Back in the day when partnership engagement grants, $150,000 were available. Ivanka Pritchard is our psychologist. We might need more of her after this closure. Chris Seitz, of course, and last but not least, the amazing Rosie Tiramarco, who was my partner in crime through the development and engagement with partners and the startup of the project. And of course, we've been we used to sit every Wednesday down at ICCNet working with their team and really building a true partnership with ICCNet. So today we're going to present the results of 3 years of an implementation project. But as a result of this 3-year implementation project, I can confidently say that South Australian country cardiac patients now have access to the best evidence-based, patient-centred, cost-effective, international standard of cardiac rehabilitation in the nation, and I'm going to go to Edinburgh on Wednesday, and I'm going to say in the world. So we will back that statement with the presentations this afternoon, but something to be very proud of, emanating from South Australian research and an all South Australian team. So just a reminder, the aim of our project was to translate evidence guidelines into practice to improve the attendance and completion of cardiac rehab for patients living in rural and remote South Australia. We used a 4-step model of translation, which was published in BMJ, and it really was based on previous work summarising the evidence, identifying barriers, measuring performance. We used the 2011 audit, and then we used a cycle of 4 E's: engage, educate, execute, and evaluate the implementation of the model of care and evidence-based practice. This afternoon, as I mentioned, you'll hear about the 8 sub-projects that were associated with our CHAP model of care: data linkage and clinical outcomes, co-designing with consumers, a business model for primary care, pharmacotherapy, and just want to acknowledge that our pharmacist Lem, who had a very catchy title, which was Medication Management, a Missed Opportunity in Cardiac Rehab, is now in the prize session at Cardiac Society in August, so that's a fantastic outcome. Also, we ran cardiac rehab CPDs, education sessions. We won a few additional grants for cardiac rehab, especially for women, and cardiac rehab for all, which is for low socioeconomic people who live both in metro and rural. And of course, the QI and accreditation project, and you'll hear all about those this afternoon. So this is really the academic ta-da slide from this project, and I've never been associated with anything like this, and I'm leading it. So we have actually 37 publications from this project. We have 62 presentations, so that deserves a round of applause from the project team, so well done, team. We have presented 29 CPD sessions to country South Australia. We've been to, we had roadshow, we've been to 6 regional areas twice, and we've worked with 72 participants on co-designing all of our programs. And just a reminder, it's to my knowledge, I don't ever remember cardiac rehab ever being co-designed with patients, which might explain why they don't want to come to a metropolitan hospital campus at 10 o'clock on a Tuesday. We've had 6 additional successful grants. We have 4 postdocs who are here in the room, and you'll meet them today. We have 2 PhD students who are both awesome. We've won 7 additional awards, and we now have a beautiful project report online, which some of you are glancing through at the moment. So if you would like a free download, please go there. So any translation project, if you've been trained in translation, you will know the ultimate outcome is to have your model of care translated into policy for practice. And we are honoured to say that the statewide cardiac clinical network have approached us about a project to implement the CHAP model of care into practice across the state. So that will be the ongoing project after CHAP concludes. So, and it is actually an outcome that we could not have hoped for, a better outcome. So it's fantastic. And it still involves ongoing. So the research might have stopped, but the translation into practice will continue. So country patients will get better, will be getting better care until the metro people catch up with us, so we can still hold that position. Unfortunately, Steve Nichols, who is CIB on this project, was going to attend live, and unfortunately, I think he's doing a ward round right now, so it was hard for him to get away, which is fair enough. But he was going to talk about the background of this project. And just to remind everyone who was there, the CATCH database was actually a project that was led by Wendy Keach when she was at the Heart Foundation, and bringing together the quality indicator measures that were needed to measure a quality cardiac rehab service was a project that Wendy started back in 2010, 2011. After that, skip forward to SAMRI, we were definitely a very active member of the Heart Group, which was one of the first 6 pillars of SAMRI. And then when the Health Translation SA Group was established, cardiac rehab was identified by Steve. That's why I'd like to acknowledge him today as an important area for research and translation. Fair enough. But what is important is that he gathered us all together in the 4th floor meeting room, and we were scratching on the whiteboard walls there about projects that we could write up for funding from the NHMRC. And it was John Beltrami who said, why don't we write up the amazing work that Phil Titterman and Rosie are doing in Country Health SA, their point of care service, their cardiologist roster, their Muse ECGs, the cardiac rehab telephone service, etc. And that was an aha moment. Everyone goes, that's exactly what we should do. And then they go, why don't we get Robin to write it all up? So that's what happened. And yeah, the rest is history. It was a successful grant. And we managed to raise $600,000 in cash, $1.2 million in partner funding, and the total grant was worth $3 million, or just near 2. So that is the background. That is what we're going to present to you this afternoon. But central and most important to everything that we have done in CHAT is our consumers. So co-designing services, implementing the evidence-based practice, everything we've done in CATCH has been co-designed with consumers. And a key consumer and his wife, Clayton and Etta Bester, have been on our journey from the beginning. Is Clayton there? I just want to point out, I found it difficult to find a photo of Esther, but then I found this photo here of Clayton and Esther in the social pages at some lovely Barossa function. So we do have Etta represented here. So Clayton and Etta are a happy married couple currently living in the beautiful Barossa Valley. They enjoy food, wine, beer, as you can see from the social pages, all staples of the Barossa Valley. Clayton especially loves sport, Port Adelaide, yay, and music, technology, movies, spooky stuff, and being open to new opportunities and adventures. And he's worked in regional media, and you can see him at the radio station there, radio and print, for over 30 years. And he's presently employed by Flow FM, broadcasting to regional South Australia, Victoria and New South Wales. So everybody, could you please welcome Clayton and Esther? I think.
Eddie.
Are
Hello?
you there?
Yeah, we're here.
Okay. Oh, double screens. Okay, very good. Welcome, welcome. Can you see the audience from where you are?
No,
No, we can see
Can
you.
you see me?
That's okay.
you see you.
Oh, we're going to click a button and you'll be able to see it. There you go. Say hi, everyone. Hi to... Fantastic. So thanks for joining us today, and I really appreciate your time, both of you. And thank you once again to both of you for your contribution to the CHAP project. It's been amazing. And I thought we would take a little bit of time in this session to reflect on your experiences and give us some perspectives of what it was like to be involved in a big NHNMRC project. So can you tell us, has your health actually improved since you've been hanging with the CHAP team?
Apart from the hangovers, do we include the hangovers? I think overall it's probably just stayed the same. It's improved a little bit, but because of that little thing called COVID, it put us a little backwards because
Okay.
we couldn't get out and do the things that we wanted to do. But over time and with other health issues that we're still working through, I think we're probably better overall.
We're better informed on diet stuff and exercise stuff and
Yeah.
heart health than we ever were.
Excellent.
That we're not alone through all this. I think that
It's been a godsend, yeah.
A couple of my favourite cardiologists are in the audience today, and they're nodding madly because they're seeing lots of heart patients who have got consequences of COVID coming through clinics at the moment. So you may not be alone there. So, but keep up the good work. So, what lifestyle factors have you changed since you went to cardiac rehab? Especially you, Clayton. What was the one thing that you're really proud of achieving after going to cardiac rehab?
Well, driving straight past KFC, I think was probably the big one. But just I think food mainly, just being very conscious of it, because one of the sessions we had was right into the diet, and when you realise that the love of hot chips and that greasy stuff, that it is really bad for you, and you can do alternatives, and you don't really need it. You can find other food sources that, if anything, are probably more flavoursome, and that has been a big thing for us is the diet. And also with our cardiologist, he's relayed little things like, if you're not hungry, then you don't necessarily have to eat. If you feel hungry, then okay, have something to eat. But just because you get up in the morning and everyone says, through the media, I work in the media, and we want you to buy the advertised products that we're selling, but we don't. If you don't feel hungry, don't have breakfast. And if you have something later on the day, work that way. Don't
make sure what you do eat is good stuff. It's not just junk food. Go for the homemade. You know what's in it. You know what's cooked in it. You know what preservatives are in it. Go for the better option rather than just go for the junk food.
And sharing food group ideas with friends as well. That tell them what we're through, and they say, "Oh, we tried this recipe," and we go, "Oh, that's not. We can do that." And so we've been doing a fair bit of that as well.
I remember when we went to the Barossa for the workshop, all of the participants in the room wanted to do a YouTube channel of Barossa healthy cooking. Yeah, they were really super keen. Yeah. And I think it's a good time now to make a plug for Carolyn and her team at the Barossa Cardiac Rehab Service, because we've learned just by hanging with you guys that they're amazing.
Yeah, Caroline is like tops in our book. Like, nothing's too hard, no question was taboo. she's just really accessible and just really a lovely person.
Yeah.
She's fantastic. Scary at times, but she's fantastic.
Scary's good. Tough love. That sounds like, it's not wasted. So based on your experience with the CHAP study, describe how you value partnerships between consumers and researchers. What were the impressions that you will take away from working together with us?
Well, one of the first, and it was probably, and I've been thinking about this over the last few days, is that whenever I heard of these sort of groups, to me it was like a group of people who were very insular. They weren't looking out, they were looking more for their own outcomes to support whatever they were trying to do. But I found that everyone was open to ideas, suggestions, because at the end of the day, you wanted to have the best cardiac care for regional South Australia in the world. And you wouldn't have got that if you'd been closed off to ideas and solutions and even just a crazy idea. Can this work? Can we try that? And I remember one of the things that I said is that cardiac rehab should be for life. And to see that is now starting to be a little bit of a reality, it's like, wow, it's like, you're open, you're listening. And this is, I feel that my small part, and I'm certainly not putting myself anywhere on the level of you guys, but my small part, if that's helped to make that a reality, it cannot be more proud of than that.
And the fact that you all listen, you just don't look at us as consumers. You look and take the ideas that we have or comments that we've had, and you go, actually, we could make it work this way, or that sounds like something we need to look into. It's not that we're just here giving our point of view and you go, okay, goodbye. You go, okay, you've made some good points. Let's have a look down that rabbit hole and see how it goes. And
we don't always tick every box. There are some that we do ticks, but there's quite a few that we don't. But the next person might tick all those boxes. So it's finding an adaptability within the program. That is one of the things that I thought was a good thing to see.
So we've got lots of fantastic clinicians and Heart Foundation people in the room today. What would you say, because you might have been surprised to learn that cardiac rehab had never been co-designed with the consumer, with the end user before, so this was quite a first. After reflecting back, give some advice to our audience about what you think the importance of that is from your perspective and experience.
I think relaying the message that what happened to me after having the heart attack, that I now had a lifetime condition. It wasn't just going to go away. It wasn't just going to be a Band-Aid and that cut will eventually heal. I've got this for life. And I went from taking 1 tablet a day to 7. So there are all these impacts and ripples from one event. And I think being able to convey that and see that it does make sense, that you're understanding that when you're going through it, writing prescriptions and such, that there is a result, and there is an impact that's going to have, not just for me that went through it, but also for Etta and her other family, our dog Nessie that's watching us all through this as well. But that was important to know that it wasn't just me that was going through, it was the family and it was others, and that you were understanding it and now being made aware of it and realizing that instead of just telling me the message, tell her, because she's listening. For the first 3 months, I couldn't even know what you were telling me. I wasn't really paying attention. I was listening, but I wasn't hearing.
Yeah.
And then I'd have to go around sort of behind his back and ask questions, because I wanted to know what to do if, or, what happens if this happens, what can I do to make him understand what's going on? So all that part of it has come through this too, So I think you don't pick it all up in the rehab straight away, but it filters down, and you know that you can talk to people and get other people's point of views to help make it easier to relay back to the person that has had the heart attack, but also to ease your own mind that you're actually doing the right thing, you're on the right track.
And so, Etta, you said that Carolyn was a bit tough at times. So
He said that. I
How-
didn't. I thought she was great.
how good a patient was Clayton, really?
Oh,
Tell us the truth, just between us.
Okay, just between us.
Yeah.
Helen and I had a conversation where I turned to him and said, "That's fine. Keep doing what you're doing. The house will be paid off, and I'll have your super."
Oh, there you go. They're the words that'll bring him into shape and give up those chips and gravy for sure.
Because he just wasn't listening, and I couldn't get through to him. And I think by saying that, sorry, the dog just wants a cuddle. By saying that, it actually snapped him out of it, and he went, "Oh, this is actually serious." But you have to tell the hard truth sometimes. You can't pussyfoot around when they're in the middle of denial and they don't want to hear. You actually have to smack them across the head nicely.
Yeah. No, I think that's in the manual somewhere. Clayton, what really motivated, apart from a wonderful, loving wife encouraging you to do the right things, translated, nagging, where did you find the motivation? What motivated you to make these lifestyle changes? Because it's tough. We know it's tough.
Because I didn't want to go back. One of the things too was a statistic that I read that said that now that I've had one, my percentage of the chances of having a second one it increased automatically by 17%. That's just automatically. And then I read somewhere else that due to COVID, that percentage had gone up to around 34, 35%.
Wow.
Okay. So things like that. So that chance of having another one, that was a motivating factor. And because sometimes when you have the second one, well, you never get a third because that's all you get. And so that was a motivation. And just that, that there is, I guess when I was in the hospital, there was a moment where you think, well, the road in front of me is not that long now. But then after a while, you start to realize, well, actually, the road's as long as I want it to be if I change my attitude and my mindset.
Sorry.
Go ahead.
I also got ill about a year after Clayton had his heart attack. So he basically had to look after me for a while. So I think that helped too, because then he realised that I'd been putting all this energy into trying to get him out of what he was going through. And as a result, when I got sick, I couldn't do it. So he had to lift the ball and look after me. So in that way, that helped as well.
Fantastic. Okay. Now, guys, would you join another project as consumer rep again? That's the ultimate accolade, I think. Just
it's something that we have to experience. Like,
do I have to have the heart attack for us?
No, you do actually. Yeah. No, I think no. We're definitely interested in carers and partners. We definitely have gathered lots of data from that perspective, and in fact, we are going to have a whole project in our next grant about the carers partners experience looking after. Yeah.
Definitely.
So, what was that? A gentle smack on the head? Is that what you said? That was. Okay. We'll get that into the next project. Would you recommend it to your friends and colleagues and in the Barossa to?
Oh, we have.
Absolutely. Yeah.
You have?
Yeah.
We've been telling them and how important that rehab group is and how it should be ongoing. And there is a recent one that has just started up in the Barossa, and I went to the second meeting a couple of weeks ago, and just within 45 minutes to see people who were sitting there all arms folded that didn't want to be there, but within 45 minutes realizing that someone else had gone through their same experience, slightly different, but similar experience to them, they started to loosen up and wanted to convey how they felt. And the next thing they're talking, and you can't shut them up. So to me, being involved in that sort of thing, I'm happy to do it. And if we can help out, we'll certainly do that.
Oh, fantastic. Now, for those of you who don't know, Clayton is also our consumer representative on our governance committee. And so I'd like to put your hands together to thank him for his amazing contribution in that role as well. So thank you, Clayton. We just had the governance committee, our final governance committee meeting before this session started. And Clayton, as you could say, see was supporting Men's Health Week last week on the radio and on his show, and he was asking us if we could have a briefing meeting about CHAP and cardiac rehab, and he's definitely going to advertise and spread the word on his show. But what are the messages that are sort of mulling around in your head, Clayton, just to finish off with a few final words? What are the key messages do you think you'll be spruiking out there over the next few weeks as an outcome of our CHAP experience?
The immediate ones that come to mind was the crew project, because when you're talking about heart attacks, it's from a very masculine kind of viewpoint. And
cardiac rehab, especially for women.
It's not mentioned. Women are the ones that they pick up the pieces after us blokes go through it. But when you actually meet a woman who's had a heart attack and what she's going through, and you think, well, I've gone through the same thing. Why are we talking about it from her perspective? That's something that's really, really got under my skin a bit, that I want to get more out there, because I think that people in regional areas where Flow broadcasts, well, the women would feel very alone. And I think they need to know that they're not alone. And to me, that's just one of the big things that I think needs to be conveyed a bit more. We need to get that message out there that heart attacks do not discriminate. They don't care. It doesn't matter where you live or what you do. If they get you, they get you. And it's what happens next. And if there are people out there that have been through it and you can talk to and can help you through it, then I think we need to keep doing that and keep pushing it. And that's why that crew project, to me, I'm quite intrigued by that.
Okay, fantastic. We can give you lots of information to get information about crew out there. So I think you have done a wonderful job in presenting to us today. And I think you are fantastic representatives of the cardiac rehab consumer community, and actually a beautiful couple. One last word, Etta. Etta's going first, Clayton.
Okay. One last word. I really love this experience of being part of the consumer and seeing what you've done with the project and that. It's really made me feel less alone having to look after Clayton. Not that he doesn't look after himself half the time, but it just takes that anxiety away a little bit, that to know that there are people out there that I can reach out to and ask questions and have support without having to sit there and worry about it all the time.
Fantastic. Last word to you, Clayton.
You guys need more funding, and whatever I can do. Thank you. Any help, I'll do.
Keep up the spruiking. Get on the radio. Tell the world. That'll be fantastic. Could you put your hands together for Clayton and Nesta Bester from... Now, I'd like you guys to make a cup of tea and stay tuned on the laptop there, whatever you're on, because you're about to be blown away and you're about to be very, very proud about the project that you've been associated with, and we acknowledge your contribution. So thank you very much.
Thank you.
So we now move to our sub-project session, where we have 8 sub-projects to present to you. Again, as I said to Etta and Clayton, you're about to be blown away by the outcomes, by the quality, by the science of the outcomes of the CHAP project. So our first sub-project presentation is from Aline. Aline Belagoli is a medical physician who actually comes from Brazil, and digital health telemonitoring is big in Brazil. So we are actually quite gifted to have her working with us because she knows this territory really well. Aline is absolute pleasure to work with, and she's absolutely the most fabulous data analyst that I've had the pleasure to work with. And so I'd like you to welcome Aline and have a listen to some of the amazing outcomes that we've developed from our data.
Good afternoon, everyone. Thank you, Robin, for your kind words. Yeah, I think I'll get there. I'll get to be the best, not there yet. But thank you everyone for coming and for listening. So I'm going to be, before talking about the CHAP outcomes, I'll just go back a little bit and talk about the background. And we know that the rationale for the country heart attack prevention project is that people in country have a higher prevalence of risk factors. And is this working? Yeah. And a higher risk of death. So there is a 40% higher risk of cardiovascular death in people living in rural and remote areas in Australia. And of course, secondary prevention is key to prevent these deaths, and cardiac rehab is one strategy for secondary prevention with strong evidence. So this is one of the forest plots from one of the meta-analyses that show that cardiac rehab is able to prevent one death for every 17 patients with acute coronary syndrome attending cardiac rehab over 3 years. And there is another meta-analysis showing that one patient, we can prevent one heart failure readmission for every 14 patients attending cardiac rehab. So this is the strong evidence that backs up the guidelines recommendation for cardiac rehab for people with heart attack, arrhythmias, revascularization procedures, cardiac transplant, and this wide range of cardiovascular condition. But we all know, and those who are familiar with cardiac rehab know, that cardiac rehab is actually more than one. So we are talking about different program durations, varying from perhaps 4 to 36 weeks that we see in the literature, different waiting times to commence cardiac rehab, going from days to months, different modes of delivery, face-to-face, and groups, individuals, or via phone, via the web. And we are also talking about different quality and variable quality across the programs. So this was one survey we had in the CHAP project with the clinicians in South Australia. And you can see by the yellow bars going up and down that this is the variability of the programs regarding their performance on the quality indicators. So there is variable quality as well. So cardiac rehab is more than one. And cardiac rehab in South Australia before CHAP was, in a nutshell, this thing here on the screen. So the patients eligible to cardiac rehab were predominantly referred to the program via the CATCH central referral system, which is coordinated obviously by ICCNet, but they could also be referred internally. So if they go to a hospital, they can be internally referred to the cardiac rehab program in that hospital. And from the CATCH central referral system, they could, if they are living in the country, they could choose between the face-to-face center-based programs, the CATCH telephone program, which is very well represented here today, and they could move across these projects and be supported to a GP through a hybrid the GP hybrid program if they were in the telephone. Whereas people in the metro areas were only receiving face-to-face cardiac rehab as an option for delivery. So this is the cardiac rehab that we had at that time. And we knew from data from 2013 to 2015, one of the audits of the Cardiac Rehabilitation Service, that only 28% of the eligible people were being referred to cardiac rehab. And only of those eligible, only 9% were attending. So this is actually an important gap in the translation of evidence, of the strong evidence that cardiac rehab has. So the aim of the CHAP project was actually to build this bridge on the gap and translate evidence and guidelines into practice in rural South Australia to increase attendance and completion. So the hypothesis was that through this model of care, we would increase attendance, completion, and as a consequence, we would improve risk factors modification, improve evidence-based pharmacotherapy, and also patient-reported outcomes and experience. And from that, reduce ED presentations, CV admissions, and CV mortality. All this would be delivered through a cost-effective model of care to patients and to service. So to test this and to refine the model and implement the model, we use the model for large-scale knowledge translation from Pronovost. So this model talks about 4 stages to implement an evidence in large scale. So the first one would be to summarize the evidence. Second one, identify the local barriers to implementation. Third, measure performance. And the fourth would be ensuring that all patients receive the model of care. So for CHAP, the 3 stages were completed in the decade before CHAP with the partnership between Robin, the research team, and ICCNet. And the CHAP is actually then the 4th stage of this model, where we had this cycle of engagement, education, execution, and evaluation of the project. So it may seem on the screen like a cycle, but we can imagine that it's actually a 3D dimension thing that happens in a loop forever and ever. So this was my feeling in terms of the implementation of the project. So this is what we did. So in terms of the barriers who were identified, there were, of course, a guide for the planning of the interventions that we were doing. So for each of the 4 barriers that were recognized, there was a series of interventions which are closely related to the sub-projects that we are speaking about today. So, for example, the first one was the limited referrals, first barrier, limited referrals to CR. So, unfortunately, we couldn't actually complete all that we had in mind about this, because the automatic referral that was originally planned in the project didn't go through. So for a series of reasons, including COVID being a major obstacle for this happening, because then resources from ICCNet had to be diverted to cover the COVID care. The second barrier would be the lack of sustainable lifelong commitment to CR supported by primary care. And what was done in relation to that was to develop a business model to be implemented in country South Australia, or perhaps in South Australia or Australia, actually, to incentivize GPs to support cardiac rehab that's being delivered via phone or via web, and also to support these patients with cardiovascular disease beyond their time in cardiac rehab, so to support them for life. So another one of the barriers is the heterogeneous quality of the cardiac rehab programs. And for that, we conducted a series of continuous professional development meetings. They were held monthly, and all the country nurses were invited and did join the professional development program. And also this will be achieved through an accreditation project that's being developed and will be implemented soon. And the 4th barrier would be this one, the lack of patient-centered approach. And for this, the CHAP model refined the current model and expanded the telehealth options through the web-based program. So the details on each of these responses to the barriers will be given in the presentations today, so I will not give a spoil on those. But I want you to bear in mind that what I'm talking about when I'm talking about CHAP, the kind of the intervention is actually this. So what we did in CHAP is all the engagement and education and the professional development, and of course, adding the web as an option to the patients. So this is from July 21 to 30th of June 22, which is the time frame of the CHAP project. To evaluate the study, we went on a journey of data linkage. And the reason we decided on that, it was not originally planned, the data linkage to be part of the project, but the reason for that is that, one of the main reasons is that we wanted to assess referral rates among the eligible patients as the quality indicators both nationally and internationally recommend that we have the referrals among the eligible patients. And the second reason was that we wanted to improve the accuracy of some of our secondary outcome measures, such as cardiovascular readmissions, ED visits, mortality, and risk factor modification. That's why then we proposed the data linkage sub-project that consisted of linking the CATCH database, which is the cardiac rehab, the statewide cardiac rehab database, where we can look for referrals, attendance rates, completion, and also risk factors. Then we linked this database with the hospital database, looking for the admissions, the emergency department database, of course, the cause of deaths, and the plan was for it to be linked with assay pathology data as well, but unfortunately there were delays in the data and this didn't happen on time, so we don't have the linkage with assay pathology. Also in the evaluation, we had 3 types of study design that would respond the questions respond well to each of our questions. So the first study design was a retrospective cohort study, which produced the results for the audit that we did for cardiac rehab from 2016 to 21. And there is a prospective cohort study, which I'm showing the results to you today as well, and a pre-post study design that is in progress. So I'm not showing the results for this part today, and they are part of the CHAP, the evaluation of the CHAP model of care per se. So what we did in the linkage for all these 3 study designs was to select our cohort from the hospital databases using about 250 DRGs, the diagnosis related codes, ICD, 10 AM, and procedure codes. And if the patient had one of these codes as a primary or as a secondary diagnosis during their readmission, and they were adults living in South Australia, then they were eligible to our study. They were selected. So with some delays, I think about 6 months of delay, we got the results of the audit. So we received about 800,000 eligible records in this audit. This led to 829,000 unique separations that were not separations in the same day. And this was equivalent to 100,000 patients. And of this, about 31,000 could be linked in the CATCH database. So this means that this is the number of patients referred to the CATCH database during the whole project from 2016 to 2021, considering 2022, sorry, considering all the 3 study designs. So 26,000 of these were referred pre-CHAP, so until July 21, and 4,915 were referred from July 21 to 30th of June 22. So this is our cohort for the CHAP study, And this is our cohort for the audit study that we conducted. So I'm going to talk about the audit results first. I'll try to be brief about it. We had a whole data meeting about this in February where we could discuss the details. And I think most of those here in the audience were also in this meeting. And also as an outcome of this audit, we provided each of the services with a report, an individualized report of their own audit of their own service. So for the audit, as I mentioned, we had 26,000 patients referred to cardiac rehab among 84,000 eligible separations. And this makes up to, just go through. So there were, the rate of referral was around 32%. The percentage of attendance was around 12% of those eligible to cardiac rehab. So we can see that we are still very much behind the international benchmarks in terms of referral rates. And we are perhaps a little bit better than we were before, according to the 2013 and 2015 audit. And in terms of attendance among the eligible, we unfortunately are still very much behind, but perhaps in an improvement curve. So in terms of completion, completion was 29% among those referred. And if we look at those that started the project and that got until the end, this makes up to 78%. So yeah, there is definitely room for improvement when we looked among those referred. We also looked at the waiting times for cardiac rehab across the years. So we can clearly see that, I hope you can, that the slide is good enough. You can see that there is a line here going down, which is a good thing in this case. So the median was 42 days for a patient to start cardiac rehab in 2016. And this has been decreasing gradually. So we had 34 days in 2021, but the average among the years was 41 days, if I'm not mistaken, which is still very much above the 28 days that are recommended both nationally and internationally. Another type of analysis that we did in the audit was to look for the clinical effectiveness of cardiac rehab, and we compared the clinical effectiveness among the groups who were not referred or declined cardiac rehab, so they did not receive cardiac rehab, which are these ones in the blue curves. And we compared them to those who started but did not complete, and to those who completed cardiac rehab until the end. And our primary outcome in this case was a composite outcome of cardiovascular readmission and overall death. And we can see that at all time points, those starting, but particularly those completing cardiac rehab, had a lower risk of cardiovascular readmissions and overall death over time. So cardiac rehab works, and so we do need to work more and more on the attendance and completion. So this was the task of the CHAP project. So now I'm going to talk about the evaluation of the CHAP project with that model of care that I showed to you, and in terms of the prospective cohort study. So in this study, we considered that those exposed to the CHAP model of care were all those patients who were referred to cardiac rehab in country, to cardiac rehab programs in country South Australia, to any of the modes of delivery, face-to-face, telephone, web, hybrid, or a combination of these modes. And our control group were those not exposed to the CHAP model of care, which are basically the ones living in metropolitan areas. So we followed them up for 12 months. So due to delays in the data delivery, we could not complete this follow-up until June, like a total follow-up of all patients for 12 months. So we have some patients with a 12-month follow-up, but most of them are within the 6-month follow-up. So for this evaluation from July 21 to 30th of June 22, we had 15,000 eligible individuals in the data linkage data set, and most of them were referred, most of them were living in metropolitan areas, as we would expect, but most of those referred were living in rural South Australia. And this is probably due to that internal referral pathway that I mentioned about. So perhaps the ones living in in Metro were being internally referred instead of being referred via the CAT central referral system. So this is one hypothesis that we have. So for the analysis, the outcome analysis, we used a matched cohort. So we matched these people here, metro and rural, by age, sex, and DRG. And this was planned originally in CHAP, and it was one of the ways that we used to try to minimize the difference that naturally occur between patients in metro and rural area, so that we can conduct the analysis minimizing this difference and trying to find out what, in terms of the outcomes, what the difference is related to CHAP, with that, considering the differences in metro and rural. So we matched this population. So for the matched population, we had some difference across them. Of course, they were matched by age and sex, so these characteristics didn't differ. But the patients in CHAP had a lower index of relative social advantage and disadvantage, which means that they had higher levels of socioeconomic disadvantage. They had lower Charlson comorbidity score, the ones in CHAP, which means that they were less severe in terms of their comorbidities were less severe when they were first admitted to the hospital compared to the ones in metro areas. And there was some difference, for example, with more people with obesity being in CHAP than in non-CHAP, and more people with hyperlipidemia also being in CHAP compared to non-CHAP. When we looked at the reasons that these patients were referred to cardiac rehab, both in CHAP and non-CHAP groups, the main reason was ACS, acute coronary syndrome, but we can see in these green bars here that the proportion of other reasons for referral, such as heart failure, arrhythmia, is actually higher in CHAP than on CHAP. This is also explained because in metropolitan areas, they have other models of care. So they have AF clinics, heart failure clinics more available than cardiac rehab. So this explains why we have this difference in referral. So for our primary outcome, which is attendance and completion, we found a higher rate of attendance among those in CHAP. And when we adjusted this rate of attendance for other things that could explain, such as the Charlson index, the socioeconomic index, and the length of stay, we still found that CHAP was associated with an 8% increased the chance of patients attending cardiac rehab compared to non-CHAP. And in terms of completion, we saw that really the raw rates in CHAP, the unadjusted rates were higher than in non-CHAP. So it was 77% in CHAP and about 48% in non-CHAP. And when we adjusted for these other confounders, we still saw that there was a 15% higher chance of patients in CHAP completing cardiac rehab comparing to non-CHAP. So this is, yeah, actually, we were very happy with these results. That's why Robin is manifesting herself. And we also looked at, which is related, of course, to the primary outcome of attendance completion. We looked at the waiting time in CHAP versus non-CHAP. So we had 38 days for CHAP, 36 for non-CHAP. So CHAP was slightly high, had a slightly higher waiting time to commence cardiac rehab. And the number of sessions in CHAP was, yes, significantly higher than in non-CHAP. So we had a median of 6 sessions in the CHAP group compared to 4 sessions in the non-CHAP group, which is still very low if we think about other international recommendations of 24 to 36 weeks of cardiac rehab. In terms of the risk factor modification as a secondary outcome, this is actually the outcome that we don't perhaps trust very much. And this is how the linkage with assay pathology would have helped us, because then we would have had HbA1c and lipids levels to be able to analyze this properly. Because the thing is, when we try to analyze this, of course, if it's risk factor modification, we must look at what was happening before cardiac rehab and the post-completion assessments. And then we have this higher level of missing values for the variables that we wanted to actually analyze. So yeah, there are some difference among the groups, but this is actually something that we are more cautious to talk about because of the number of missing values. In terms of the other secondary outcomes of CV mortality, CV readmission, and ED visit, the unadjusted rates were higher in CHAP than in non-CHAP. But then when we adjusted, we saw that there was no significant difference in terms of cardiovascular mortality, cardiovascular readmission, and ED visits between CHAP and non-CHAP. So, of course, we must acknowledge some limitations of the data. So metro and rural are very different populations. We applied statistical methods to try to minimize this difference and see how much of the CHAP outcomes are not related to this difference. But of course, there is still a possibility that residual confounding exists between in our models. And that some of these differences are related to actual difference in characteristics between metro and rural people. And that's why it's important that we finalize the pre and post comparison, because then we are comparing people in rural pre-CHAP with people in rural post-CHAP. So these differences are minimized by that way. So we will be happy to be presenting this in our papers and our other forms of dissemination when it's ready, because we only had 2 months of data to do all this. And of course, another limitation that is related to the difference in between metro and rural are the different eligibility criteria between metro and rural in South Australia. And this was something that we identified very early on in the project. And we had this meeting with the coalition, the Cardiac Rehab Coalition group, where we discussed whether we should analyze this differently, particularly for the audit. The decision in the meeting was, no, let's go, because this is the evidence is for all the conditions. Let's not restrict the analysis to those with ACS, which are the only indication that's used in Metro, actually. So we also have this as a limitation. As I mentioned, due to delays in the data, we don't have complete 12-month follow-up to all patients. We have these issues with the missing values affecting the quality of our data and the fact that we couldn't do the linkage with SA pathology in time. And we, although we were able to implement these measures in the CATCH data set, so the measures of quality of life, the medication adherence questionnaire, and anxiety were introduced into the CATCH database and are now being collected as part of the routine care of the patients going to cardiac rehab. This was also not done in time to allow us to have data to analyze these 3 outcomes. So we will have this as kind of missing outcomes. And of course, one of the most important limitations is that we couldn't actually implement e-referral. And so we are still missing people referred. And if we think that it's about 30% of those who are eligible, who are being referred, this is the main point that we should focus and really have a strong implementation around referral. So to conclude, we found that the CHAP model of care, through providing different modes of delivery to patients, through providing support to patients in cardiac rehab via primary care support, and all the quality improvement that was developed with the clinicians and through the accreditation program, they led to this improving attendance and completion for people in country areas in South Australia compared to non-country. So this is it. Thank you. I'd like to acknowledge the data linkage sub-project team. And thank you, everyone involved, particularly those in ICCNet, those sending us data, the staff in ICCNet that sent us data that were always replying to our questions. What is this in the database? What does this mean? What does that mean? So thank you very much for this partnership. So I will now move on and would like to invite Sarah Powell to come to the podium and talk. So Sarah is our project manager. She comes from a project management background in the health industry and in other industries as well. And Sarah has been, I think, our greatest present, greatest gift in the last 1.5 years of the project. Her support is amazing. It's just unbelievable. Thank you, Sarah.
Thank you, Eleni. We'll just save the questions until we just have our break. So we'll have 4 presenters. The next 3, including mine, are a lot shorter than Eleni's. Eleni had a lot more to share, and we've kept ours short for you. So I do have the pleasure of talking about the team projects and achievements, which Robin alluded to in her welcome. So just giving you a bit more information. So the team is led by Robin Clark, which is fabulous. We also have Rosie from ICCNet, part of the project team. Myself as a project manager, we've got our 2 PhD students who will be talking with you shortly, and our 4 postdoc researchers. We have our data manager, John, who's at the back of the room, and we also have our extended cardiac care team. So some of them aren't here today, but we just wanted to do a shout out to Professor Jeroen Hendricks and also Dr. Alejandra Pinero Plaza, who unfortunately can't be with us today. But we do have a recording from Alejandra that we will share about her project. So Robin did allude that we will have 37 CHAP publications. At the moment, we do have 24 that have been published in many different journals. And the lists are in the final report, so you can have a look at those, and also on our website. We have 4 papers that have been submitted, but they're under review, so we're just waiting to hear. And we have 9 that are in development, so they will be ready at the end of June and early July. So huge effort from all the team. And we have presented, or we will have, as at the end of June, at 50 different conferences and workshops, all the CHAP results, which is a huge amount of places to be. And we've got 12 abstracts that have been submitted for the Australian Cardiovascular Health and Rehab Association conference that's coming up, and also Cardiac Society of Australia and the European Society of Cardiology in Amsterdam. So they're all coming up in August. So we will have presented at 62 different events, which is a massive amount of effort from all the team. So in regards to education and engagement, we have had the 12 co-design roadshow workshops, and they were held, we actually had 74 participants involved, so they were our consumers that Clayton and Etta were part of, so they came to these workshops. And we've got some photos there of some of the people that are in attendance. We had continuing professional development sessions from June till December 2022, and we've got all of those that have been recorded and are available on our website. And Joyce will tell you more about the evaluation of those. We did have 3 seminars that were open to the public. So we had people come and talk about various cardiovascular issues. And 6 showcases, which is our final one today. We also ran a data workshop, so we were looking at evaluating the quality outcomes of cardiac rehabilitation in South Australia in February, and we did that with a number of partners, which was great, and came up with some recommendations to the statewide cardiovascular network. We've had a number of videos recorded, which, yeah, they're included in the final report as well. And we've done 22 CHAP newsletters, so they're a monthly newsletter. And you can go back and look at those as well. So we have been successful with a number of grants over the last couple of years, which is very exciting, including CRUL, which is Cardiac Rehabilitation for All, and CRU, which you've already heard this morning, Cardiac Rehabilitation especially for Women, and we'll go into those a bit more after the break. We did win a couple of Flinders University research infrastructure funding grants, which we were able to put towards technology, buying new laptops and computers. And Robin and her team have recently won another NHMRC partnership grant, which is called Safe at Home, and that's kicking off on the 1st of July. So it's been a massive effort from the team to be able to get all those funds in the door. We have to work out what the percentage is of how many we actually submitted, as opposed to what we were successful. In regards to team awards, we were a finalist in the Solve CHD video competition, and that is actually being announced this week. So we'll hold our breath and see. Our PhD student, Aura, was successful in winning a poster prize at the Cardiac Nursing Symposium, and we do have the poster on display, so make sure you have a look at that one. And we were a finalist as well at the ACVA Translation Award. So that was for improving low uptake of CR programs. So that was very exciting, and Robin went over and received the award. And this is one of our papers that Katie was a lead author on. And this has actually been announced as a top downloaded paper in 2022, and she's actually being acknowledged for that in Scotland this weekend. Yeah, so that's huge. And Robin won a VPED Research Award as well as Alejandra. Oh, sorry, Eleni, who did I say? Oh, Robin. Eleni won an award in 2021 and Alejandra won in 2022, so that's very exciting for our team. And Eleni was also nominated to be part of a research leadership workshop after receiving that award, which was very exciting. And we had both Lemlem and Alejandra that became CV champions this year by undertaking training. So huge effort from the team on the awards. And just in regards to social media, we do have Twitter. We've already put some posts up today, so make sure you get in there and like them. But we did get over 650 followers, and as you know, it is quite hard to get followers on your Twitter account, so that's quite good. In probably, a year and a bit, we haven't had Twitter that long. YouTube, we have over 30 public videos and hundreds of exercise videos that are part of our website. And we've had over 6,000 views on our public-facing website. So all of the resources and all the projects that you'll hear about today are available on our website, and that will actually stay available for the next few years. So feel free to share it and get up there and have a look around. The final report's up there as well in electronic format. So I'd just like to say thank you for everyone involved in the project. It has been fantastic. And next up, I'd like to invite Katie. I'll just bring her slides. Who is one of our PhD students, and her thesis has been focusing on the web-based cardiac rehabilitation, development, implementation and effectiveness. So come on up, Katie.
So Eleni's already spoken to the effectiveness of cardiac rehab, and we know based on what she shared today and in the literature that it is still poorly attended. And obviously that's a bigger issue for people living in rural and remote South Australia, which is where I come from, so I can testify to that both as a person and clinician. But we do know that web-based digital remote cardiac rehab is effective, and in some cases a preferred option for those who have no intention or no ability to go to cardiac rehab. So the aims of my project within CHAP was to develop and implement a web-based cardiac rehab program to improve access for those populations in rural and remote areas. So the three objectives: to systematically examine evidence on the effectiveness of web-based cardiac rehab programs on completion, to co-design and implement a web-based cardiac rehab program, and to evaluate the effectiveness not only of the program but the implementation process itself. So we wanted to know, when we did the systematic review, what the effectiveness of interactive web-based cardiac rehab programs versus standard care on program completion in patients with cardiovascular disease is. So I used a JVI systematic review effects methodology, and that's published, the protocol of that is published in Prospero. And the completed review included 9 studies involving 1,175 participants. And the quick summary of that systematic review is that web-based programs were 43% more likely to be completed than usual care. We didn't find any difference between the two groups for their clinical outcomes, which is quite consistent across the literature, and also the only 2 previous systematic reviews that had focused in on web-based cardiac rehab. So from that review, we did have a small number of studies. Completion is not something that's been prioritised in randomised controlled trials to look at high heterogeneity and limited outcome measures. However, the results did favour web-based cardiac rehab around program completion. So the second part of the project was the development of the web program itself, and obviously this has been talked a lot about probably in the last 18 months. We used a multi-methods approach, and I used the user experience or UX design, which Sarah just showed. We were able to actually write a methodology paper in itself on that, and we did co-design development workshops, and then went back and did usability testing workshops. And so we essentially used an observational assessment approach and used psychometric testing using the system usability scale to get our outcomes and to report on that. So from our web development and usability testing workshops, we did have a mean usability improvement score of 6.9 from when we asked and tested in our web development round to our usability round with the completed website. We also, apart from getting design specifications and, you know, how we created the website, we did seek to understand people's experiences around their cardiac rehab journey and also their journey with their cardiovascular condition. So the overarching theme that we took away was fear of the unknown, and I think we've heard about that this morning, but then there was usability, format of information, connectivity and behaviour change, empowerment. So a fairly broad range of issues that came out of those workshops. So the final part, and as Eleni said, I'm almost done with my evaluation, but we've been, you know, racing to the end with our data. So just evaluating the web program itself, and it was both looking at outcomes for the people using it, but also outcomes for us implementing it. So we used the RE-AIM implementation framework because it has been an implementation project. And those patients that were eligible for cardiac rehab and living in rural and remote areas were the people we looked at between July 2021 and June 2022. So I've just got a quick summary of a few outcomes. So we had 828 people that we looked at, and 50 of those chose the web-based mode of delivery. Our web patients were younger. There was no difference between gender between the two modes of delivery, and our web patients started with a mean BMI that was higher than non-web. And this slide just shows enrolments, and I'll have to explain it because I've made it nice and big, so there's not much else on there. So you can see the blue is non-web, green is web. And so in the months of November, January and February, and the numbers you're looking at are percentage of enrolments, there was quite a steep uptake in the web enrolment. So even though the numbers were low overall, there was a spike in enrolments and a drop in non-web, and that was directly correlating to COVID pandemic restrictions. So our face-to-face services had to shut, so no clients could actually do a face-to-face program, and so clinicians were able to offer them the web program either as a standalone or as a sort of step in the gap while they were waiting for their face-to-face program to be made available to them. Program completion was higher for non-web than web-based patients. However, those patients that did the web-based program were 100% completing their data entry at the beginning of their program, and 50% completed their exiting post-assessment information. So we had really good uptake of that. There was no change in risk factor between the two groups. And the web-based program enrolment, as I've just said before, was associated with a lower chance of cardiac rehab completion, and that was after adjustment for age and gender, and still just exploring some other things that might have impacted on that. We did ask both patients and clinicians what they thought, and as you can see, the web-based patients reported a 77.8% satisfaction, and clinicians reported the web-based program as high quality at 71.4% of them. So the web-based program has proven to be an alternative flexible mode to complete cardiac rehabilitation. It did meet the demands of the COVID pandemic restrictions. It has been integrated and successfully used by patients and clinicians, and we do believe it's captured a cohort of those people who could possibly fit into that 20 to 50% not attending a program at all. There's always a need to look at the reasons for non-completion, and I believe that's I've got in our web-based programs, but even across the board, that deeper understanding of why people aren't going and trying to address those needs as well. I just put up my first author publications because it's been a busy time. And I first and foremost wanted to say thank you to the people who came to our workshop and gave us their time and knowledge. We met a vast and interesting group of people, and also the clinicians who collaborated so closely with us and were so very generous to us as a team and to me personally, and to my supervisors and the CHAP team at large, because it's been a huge learning experience. They're great teachers and have been very supportive. Thank you. And I'd like to introduce Norma Bulamalu, who is our Health Economics Research Fellow, and she's going to talk to you about the health economics analysis of the CHAP model of care.
Thank you, Katie, and thank you everyone for coming to our showcase today. So I'll just take us through what we've done in terms of analyzing the health economics of the CHAP model of care. The three things we've done under health economics have been to look at the cost effectiveness of the CHAP model of health services compared to non-CHAP or usual care. And then we've also looked at the cost of the CHAP model to rural and remote patients and their families. And then we also designed a business model to incentivize cardiac rehab in general practice. The business model was done in collaboration with a consultancy, Brent Knows Health, and thanks to Danny, who is here today with us. So, like Robin said at the beginning, the main disclaimer is that our results are preliminary results. We're still looking at our data in terms of the effectiveness, clinical effectiveness, and also cost effectiveness. So these are preliminary results, and we will have more up-to-date results, I think, when we publish our papers. So in terms of cost effectiveness, the key things that we look at is, one, we look at the cost, and we looked at the cost to the healthcare system, and then we look at effectiveness, and the primary outcomes for the CHAP model of care were attendance and completion of cardiac rehab. And then we then look at the incremental cost and effectiveness. How much more does CHAP cost than usual care, or how much less does it cost compared to usual care? So our results currently show that CHAP was more effective, CHAP was slightly more effective in terms of attendances. So we had more attendance in the CHAP model of care than the non-CHAP. And then also we had more completions with CHAP than non-CHAP. So at this stage, we are saying that CHAP has between 50 to 60% chance of being cost effective compared to non-CHAP, if at least we are willing to spend 1,000 shillings for not shillings. I'm from Uganda and money is in shillings. Anyway, if we are able to spend at least $1,000 for every attendance or for every completion. So if we're willing to put in that amount of money, then CHAP has between 50 to 60% chance of being cost effective. So the next thing we looked at was how much it costs for our rural and remote patients to attend cardiac rehab. And the average out-of-pocket expenditure was $131 per patient to complete cardiac rehab. And most of the cost was towards pharmacy items, the medications that they have to buy every 30 days. And then also there was a significant cost towards travel. Actually, we had one patient who had to pay about $500 for their flight to Adelaide to attend their cardiac rehab session. That was really an outlier. And then, of course, because of the CHAP model of care, some patients had to spend about 13% on phone calls, and then the wage loss, time off work to come and attend cardiac rehab. And we also noted 7% of the cost was towards carer costs. They needed carers to either look after children or look after their home or their farms while they're away attending cardiac rehab, or a carer to accompany them to the cardiac rehab session. Under other, we had costs such as their out-of-pocket expenditures at the GP, their lunch while they are attending cardiac rehab, their accommodation was under the other costs. Then we move on to the third objective, which was to design a business model to incentivize cardiac rehab in the general practice. The main goal here was still to increase access to cardiac rehab for patients in rural and remote areas. This business model it was designed based on Medicare items that were previously underutilized. So it's completely in line with the chronic disease care management plan. And so we looked at what items in Medicare are not utilized that can actually contribute towards cardiac rehab for the patients, and what benefit would this have if they were implemented at the GP practice level. So in this model, we proposed that there would be 4 assessments, one at 1 to 2 weeks post-discharge, then 8 to 12 weeks, and then at 6 months, and then at 12 months. And all this would be carried out in the GP practice with the help of the practice nurse. And then it also includes extra allied healthcare assessments that can be done, such as with the physiotherapist, with the dietitian, and also with the pharmacist to help the patients with their with understanding their medications and how to implement this in their routine lifestyle. And then in the model, we also propose, though we don't cost this part, but we also propose, in line with Heart Health for Life, we propose that the GP can actually have a review at 18 months and at 24 months. This is to support phase 3 cardiac rehab. And like Clayton was saying, it's Heart Health for Life. So we are looking at how can the GP help them throughout their lives. So for phase 1 and 2, which stops at 12 months, in our model, we see that the GP can be able to make about $800, and this is for the non-Aboriginal and Torres Strait Islander patients, without those additional items for the First Nations people. We would be able to make about $797.15 for every patient who will complete cardiac rehab. So we see that this is something that's beneficial to the GP practice, and so we've done road shows to speak to GPs in the country and practice nurses to incentivize them to say this is actually beneficial if we can implement cardiac rehab for our patients who you see in your GP practices, as opposed to them having to come to a central cardiac rehab facility. So this value proposition presents a business case, and it has positive health outcomes for the patients, and also with a holistic approach to Heart Health for Life for the cardiac patients who are seen at the different practices. Thank you very much.
So congratulations to this outstanding group of CHAP project PhDs, postdocs, and of course our project manager. Are there any questions from the audience about the presentations? Okay, I've got a couple. Could I ask, I'm going to go a positive and a negative question. What was the biggest data challenge in looking back over the CHAP years for you? And that includes you, Sarah. It might be getting the team to respond to your emails when you're asking for. So, Alini, what was the biggest, what would you say?
I think it was actually the governance process for the data linkage. So it took much longer than we were expecting. So this is actually something that we would like to, if we are implementing health services, and we need to evaluate, and we would need to get data linkage in an easy way, I think. So this was the main thing, and this led to a whole of delays in the data, and yeah.
So what Alini is talking about, if you have only ever done metro research, is that if you go into rural South Australia, you need to approach 6 governance committees and get 6 sign-offs completed. Yeah, so it's a huge workload. It's very expensive in time and manpower. So, yep, that is definitely something we should try and... Sarah, what's your biggest data challenge in your role? Or any role?
Probably getting the data. So I spend a lot of my day chasing and following up. Yeah, so I think it's more keeping on top of what you need to get and making sure you can get it.
People saw those amazing slides and everyone was like, wow, but they have no idea how much work was in the background of Sarah nagging us constantly, send us your abstracts, send us your papers, how many, send me the details of the award. So thank you, Sarah. It definitely was a challenge. How about Katie? What was your biggest data challenge?
Yeah, well, I think from a different perspective, from a leaning waiting for the data, just research is like building a house where I think you just have to add another 6 months before you've even started. So, a little bit of panicking going on, but learning to be patient and work that bit harder and a bit faster once you do have it. Yeah, so I think for any future project, I would always try and factor in that there might be more time at the other end. But I do also agree that if we are all about implementation science, which we should be, because that's where we receive the best care and we receive it, immediately. The access should, obviously we all need to comply and do things correctly, but we need to find more direct, sort of efficient ways of connecting.
Thanks, Katie. Good answer. Norma, you're going to talk for 30 minutes now about your data challenges. Just one.
I think the delays in the data, as of last night, I was still trying to run the model. So, and it's because we've had significant, massive delays in our data. So,
So, yes, yeah. Now, to finish on it, very high, reflect on the CHAP project experience working in the team, which is now starting to come to an end. What's the one thing that you are most proud of leaving the CHAP project now that we are winding up? What's the one thing that comes to your mind that says, I'm really proud of that?
I'm proud of the team and the team effort and being able to work together and push each other and support each other, even when your data is not about to come, it's not yet there. There's team to say, it's okay, we will get there. So I think that's my biggest, the biggest thing I'm grateful for.
Fantastic. How about you, Kate? You've got a long list as well. Just pick one.
Well, no, probably my top is having the ability to work with people who live in rural and remote South Australia. It felt like such a privilege. It still resonates with me now. They were so generous with their time. And also, I'm from country, so I can always say we're amazing in the country, but the clinicians were just outstanding. And some long-standing friendships and relationships have come from that. So, that's been a privilege.
Fantastic. Sarah, what are you most proud of having worked with the CHAP team?
I think seeing the results in print, so the final report looks amazing, and to be able to capture everything that the team has done and put it in one spot has been a really good achievement.
And it really is a beautiful report. Thank you, Sarah. Alini, finally.
Yeah, I think I'm very proud of the partnership in general. So the partnership with ICCNet, with Heart Foundation, and that's how we got the spin-off grants. And mostly, as Norma was saying, the partnership among the team members, because it's a very good team to work with. So this is
fantastic.
This is good.
Well, that's a lovely high to go to a break. It's the CHAP team's pleasure to shout you all a coffee or tea from the kiosk out the front there if you would like, or just take a loo break, and we'll be back at 10 minutes to 3. Hi everybody, if we can come back to our places. We have 4 more 7-minute sessions. As I mentioned earlier, she's going to be presenting in the Cardiac Society prize session, and I'd like to take this opportunity to thank the Heart Foundation for a travel scholarship to go to Accra. Accra, you're also in the prize session at Suzanne, sorry. She's also going to Accra to present her paper thanks to the Heart Foundation Travel Fellowship and another fellowship from Accra. So thanks to the Accra guys as well. We really appreciate that. And here's a great demonstration of your fantastic investment. So let's hear a little bit about Lem's work on evidence-based prescription and patient-reported experiences in the CHAP study. Thanks, Lem.
Thank you, Robin, for the introduction and all the kind words. So as mentioned, I'm going to present on the evidence-based prescription and as well as patient-reported experience. First, I will start with the evidence-based prescription. A bit of background, as you all know, evidence-based prescription is the most recommended practice that should be given for for secondary cardiovascular prevention, and the most commonly recommended class of medication for SAS patients, as you know, are antiplatelet, statin, angiotensin converting enzyme inhibitors or angiotensin receptor blockers, and beta blockers. And for this class of medications, it has a lot of evidence that they are effective in reducing admission, mortality, and morbidity. But despite these all benefits, the translation to clinical practice is limited. So even worse for women, while they are having high risk of cardiovascular disease, they are under-prevented, under-treated for secondary prevention. So the objective of this project is to assess the level of evidence-based prescription and associate it with clinical outcomes and also gender-based classification. And we used a retrospective design, cross-sectional design, and we focused on SAS patients who have been discharged from hospital, who attended cardiac rehab in 2018 and 2019, who have also medication details in their discharge, and we linked all this data to their clinical outcome for mortality and admission, and we used logistic regression and Pearson chi-square for the analysis. So the result we got, as you can see, is we started from all participants who have been involved in cardiac rehab 2016-2017, around 13,690 patients. Of those in the duration period that we enrolled is 2018-2019, we had 1,993 patients, and we included only 1,229 patients who have complete medication and the inclusion criteria fulfilled. And of these participants, 74.6% were male, and 41 of them had myocardial infarction as their primary diagnosis. And when we see the evidence-based prescription, we only found like 39.7% of them have been prescribed evidence-based or optimal prescription, and around 78.1 were having any 3 drug class combinations, any 2 drug combination were prescribed for 94%, and one drug class were prescribed for 99% of them, which means around 1% they didn't get any of the classes of recommended medications. And association with hospital admission, we found that optimal prescription had less hospital admission, which is statistically significant, but no association with gender. But we also found that women has less likely been prescribed with SE inhibitors, ARB, statins, as well as combination of antiplatelet and statin. Any 2 or 3 drug class combinations were less prescribed in women. So when we go to the second project, that's patient-reported experience, we analyzed all participants who have been involved through all modes of deliveries, and we collected all the data in 2022 patients, and we analyzed descriptively. And for classification, we categorize them into before, during, after CHAP, as well as CHAP and non-CHAP participants, and we used mixed method analysis. So when we compare the before CHAP and after CHAP, as you can see, there has been a significant difference between the two groups, where the during and after CHAP participants were having higher score of PREMS than the before CHAP participants. And between the CHAP and non-CHAP, still significant, where the CHAP group had much higher PREMS score than the before CHAP participants, statistically significant. So we also analyzed the qualitative data of these participants, and the positive outcomes we got, we classified them into themes. And as you can see, participants were very happy with the education and information provided. They were happy with their questions being answered, friendly advice, reassurance and encouragement, and staff well informed, all that, with some comments. As you can see, they were happy with the overall programs they got. And they also recommended some improvements that need to be made, and the outstanding one was they want cardiac rehab to go for life, like the consumers were suggesting. And they also wanted the waiting period to be less than it is currently now, and more exercise options, as well as they also suggested use of audiovisuals for telephone program participants. And at the end, I want to acknowledge AstraZeneca for the fellowship, and as well as the wonderful ICCNet for all the support they had throughout these projects. Thank you very much. And the next presenter is who? So I would like to, this was Joyce. So next is Dr. Joyce, and she is a senior lecturer and course coordinator at Flinders, and she's going to present on clinical engagement and updating evidence-based for country rehabilitation programs.
Right, good afternoon, everyone. So today I'll just give you a very brief background and some of the outcomes from our continuing professional development program, which we ran from 2020 to 2022 as part of the CHAP model of care, targeting clinician engagement and updating evidence base for country rehabilitation practice. So just to give you a brief background, one of the main barriers to cardiac rehabilitation and adherence or completion, which was identified by our team in the last decade, is really around the variability in the quality at which cardiac rehabilitation programs are delivered by different services. And therefore, as part of this CHAP model of care, we aim to educate clinicians on the most up-to-date evidence to really help the clinicians to improve the different components of the cardiac rehabilitation program. And since cardiac rehabilitation programs delivered by different services around South Australia is generally based around that National Heart Foundation and ACRA guidelines, which comprise of about 10 modules, including initial assessment and goal setting, your heart education and self-management and so forth. Our team then decided to run a monthly CPD program, with each month targeting different modules of the cardiac rehabilitation guideline. And these were held every second Wednesday of the month at 1 p.m. and were all delivered 100% online. And here are just some examples of the different sessions that we conducted in 2022. And as you can see on the left there, in July 2022, we targeted Module 5 of the Cardiac Rehabilitation Guideline on tobacco cessation and alcohol reduction. And for this session here, we invited Professor Jacqueline Bowden to talk to us about alcohol, tobacco, and other drugs used in rural Australia and their implications for cardiac rehabilitation. And since 2021 onwards, we started monitoring or recording the total number of attendees of our CPD sessions. And you can see there that in 2021, we have 7 months worth of data. And then in 2022, we have 10 months worth of data, including evaluation data, which I'll talk to you about later. And on the left side there, you can see that the total number of attendees almost doubled from 2021 to 2022. And on the right here, you can see that August was our most popular month, where we targeted Module 7, Managing Medical Risk Factors, which was quite interesting. And on the left side there, as I mentioned earlier, we have 7 months worth of data in 2021 and 10 months worth of 2022. You must be saying to yourself, well, Joyce, there's a difference in months there. That's probably why you get a double in attendance. But when we look at the average number of attendees per month between 2021 and 2022, you do see that there are 14 attendees per month in 2021, whereas in 2022, we do get an increase of 20 attendees per month. Although this was not statistically significant, but when we took the CPD session in December out of the equation, where all the clinicians, let's face it, are probably on holiday, we then get a statistically significant difference between the years. So that was interesting. And after each CPD session, we also asked our attendees to fill out a survey, an Uber-like survey at the end. So 3 simple questions we asked. One is, how interesting did you find the presentation? Second was the presentation even relevant to your role or your service? And the third one was, well, was the information of the session likely to have an impact on how you deliver care? And out of all the attendees, 44% actually completed our survey, which was very helpful. And of these respondents, you can see that the majority of them, so 84%, actually found the presentation interesting, and that the presentation was relevant to their role or their service. And lastly, that the information of the session was likely to have an impact on how they delivered care. So that was very, very promising. All these CPD sessions was also recorded and uploaded onto our website, so www.chapproject.com.au, as you can see there. Thanks to Sarah for all her hard work on this space. And you can see that up to until last week when I looked at the data, 6,115 have viewed our online sessions, and 128 of these were directly from YouTube and 5,987 through our website. So very, very promising. So in summary, I can say that the increased average number of attendees in our monthly CPD session really indicates that there may be a need for further education and training to improve the quality of care provided to patients. And by attending these sessions, healthcare professionals can then stay up to date with the latest research and best practices in the field, which can ultimately lead to better outcomes for patients. So where to from here? So the CPD sessions, we would recommend to be continued by a future accrediting body of cardiac rehabilitation services in Australia. And I know Professor Robin Clark is really working hard, so hopefully she works her magic. Here's a thank you to everything that you've done for us and the team. But really what we perceive the CPD session to go forward is to kind of copy or model it or copy the way the International Council of Cardiac Rehabilitation Prevention and Rehabilitation, or the ICCPR, does their CPD professional development for all their services that are accredited through their organization. And hopefully the Heart Foundation and ACRA takes this challenge up. Thank you. All right, so next up we have our wonderful PhD candidate, Aura Sivkinor, to talk to us about our CREW project, a very important project that we have. So over to you.
Thank you, Joyce. Good afternoon, everyone. I'm Aura. Actually, my name is Aura Sivkinor. Today, I'm proud to present the cardiac rehabilitation, especially for women, or the CREW project. This is a co-design and evaluation of the cardiac rehabilitation program that tailored to needs and preferences of the women who have the cardiovascular disease. I would like to give you some background and significance of the CRU project. As you know, despite the many positive effects about the cardiac rehabilitation, unfortunately, it is underutilized worldwide, especially among women. In Australia, only 20 to 50% of eligible patients attend the cardiac rehabilitation. And also in South Australia, cardiac rehabilitation attendance rate among eligible patients were approximately only 9%. As you can see from the figures, you will see that women were less likely referral to enroll in and complete the cardiac rehabilitation program. And there are several studies have shown that many cardiac rehabilitation programs are not often designed to meet women's needs and preferences. So for our CRU project, we aim to redesign an existing web-based cardiac rehabilitation program to increase CI attendance and completion among women, as well as to improve the clinical outcome among women who have CVD residing in rural and remote South Australia by tailoring an existing web-based cardiac rehabilitation that Katie mentioned before to meet women's needs and preferences. So let's have a look at the CRU project. We divide the CRU project into 3 phases using multiple research methodology. The first phase is about understanding women's needs and preferences regarding the cardiac rehabilitation program. And then the second phase, we plan to co-design the CRU model cardiac rehabilitation program or the CRU model of care. And then testing the usability of the CRU model of care. And for the last phase, we plan to evaluating the impact of the CRU model of care. For the phase 1, we are conducting a systematic review entitled Effectiveness of the Alternative versus Traditional Form of Exercise on Cardiac Rehabilitation Program Utilization in Women with or at high risk of cardiovascular disease. And now we have 16 articles included in our systematic review, and we are working on the data extraction process. And our systematic review protocol has been accepted for publication by JBI. And the phase 1B, actually the previous one is a 1A. This is a 1B. We also explore the women's needs and preferences through the qualitative approach. So we did the workshop with the women across 6 rural regional South Australia. And we have 19 women participated in our workshop. And we have found that 6 themes were identified. For example, the first one is about the financial concern. So women need some support about financial regarding cardiac rehabilitation. For example, they need the support for transportation and the child care when they attend the cardiac rehabilitation program or the medication course. And the second one is about the importance of early education and support. We found that women need some educational content on the women-specific issue. For example, they need the education about the bras after they have a cardiac surgery. They need, and they need the educational content about pregnancy, preeclampsia, for example. And the third one is about the educational session delivery. They prefer the educational content delivery by healthcare professionals who are expert in that area. And also they need many media to deliver the educational content, such as the video, podcast, or the short text. And the fourth one is about the exercise promotion, cardiac rehabilitation participation. The women mentioned that they need educational content or video about alternative form of exercise. For example, yoga, Pilates, boxing, dancing, beyond the traditional gym-based exercise, for example. And the fifth theme is about the care. They mentioned that cardiac rehabilitation nurses is key professional who support them to engage cardiac rehabilitation program. And the last beam is about technology and resources. They mentioned that they're open to use the web-based cardiac rehabilitation program because they don't have to wait for referral and start the cardiac rehabilitation program for a long time. So we got many feedback from them. And for the second phase, we redesigned an existing web-based cardiac rehabilitation program to meet women's needs and preferences that we gained from the first phase. So this is show the example of the CR web. Now we call it CR web for women. This is the storyboard and also our first prototype of the CR web. And when we got the first prototype of the CR web, we test the usability testing by conducting the usability testing workshop at the rural region of South Australia. And now we have 5 women participated in our workshop. And we assess the e-health literacy scale and the usability scale. And we found that actually, we conduct 2 workshops with women participants, but we just finished the second workshop yesterday. So I just show you about the result of the first workshop. For the e-health literacy, we found the sum score of it is 25 out of 40. And the mean system usability scale is 80.5. It means that good usability for our CR web now. And in the future, we plan to revise, or now we're revising the cardiac rehabilitation web with IT developer, and we plan to roll it out in the early of July and test it as our third phase to evaluating the impact of the CRU model of care or our CR web. For the recruitment, we plan to recruit the women by send them the invitation card that will be included in the My Heart, My Life packages. And we will provide these packages with to the patient after they discharge from the cardiac event. And then participants can enroll themselves to the CR web immediately. And also they can use the CR web along with the existing CR mode now, like face-to-face, telephone, or hybrid CR. This is for the CRU project that we have done and the plan in the future. Thank you.
Thanks, Laura. What we've got next is, before Robin, we actually did a recording of Alejandra's video because she couldn't join us today. We just don't have sound.
By Dr. Aline Belegoli, and it was co-developed by a big team of fantastic co-authors who passionately work on cardiac rehabilitation for all. This work was led and is led by Dr. Aline Belegoli, and it was co-developed by a big team of fantastic co-authors who passionately work on the project and the results that I am presenting to you today. We call this project Cardiac Rehabilitation Utilization, its clinical effectiveness, and barriers to completion among patients of low socioeconomic status living in rural areas of Australia. This study is a mixed methods study. So we know the cardiac rehabilitation significantly improved capacity and reduced traditional cardiovascular risk post-discharge. However, the utilization of cardiac rehabilitation programs remains low globally, particularly among patients with low socioeconomic backgrounds. People with socioeconomic disadvantages, principally those living in rural areas, have higher risk of cardiovascular events. Their cardiovascular death rate is higher for both males and females when compared with high socioeconomic status people and areas. In low socioeconomic areas, psychosocial stressors for economic instability, limitations in neighborhood-built environments, education, healthcare access, and social relationships contribute to the increase of cardiovascular risk. These issues are more prominent in rural areas than metropolitan areas, as socioeconomic status is typically lower for such locations. So patients from low-income areas, including those living in rural areas, are less likely to attend or complete cardiac rehabilitation programs. These situations and characteristics highlight the necessity to investigate and to address these and other barriers to completion and understand the specific needs of these particular populations. So considering the background that I just presented, we aim to understand cardiac rehabilitation and its effects on hospitalizations and mortality amongst 16,159 hospital admissions of patients with low socioeconomic status here living in rural Australia. The study involved all South Australian hospitals, public hospitals, and 15 public cardiac rehabilitation programs in rural areas. These cardiac rehabilitation programs included core components such as referrals and access to services, clinical assessment, recovery and long-term maintenance, lifestyle and behavior modifications, and evaluation and quality improvement. The study employed a concurrent triangulation mixed method design. This means combining a retrospective cohort study and a qualitative study. So the quantitative component assessed the cardiac rehabilitation utilization and clinical effectiveness by linking clinical and administrative data sets. And the qualitative component involved conducting semi-structured interviews and focus groups with 28 participants to explore the barriers and needs related to cardiac rehabilitation completion. So the third component is basically what allows us to complete the triangulation, which is the convergence of these results from both quantitative and qualitative data sources. So following that methodology, we found that only 11.2% of the eligible patients completed their program. But we also identified that completing their program reduced the risk of hospitalization and mortality. In reference to the barriers, we identified that being old, living alone, or having diabetes or depression and being enrolled on the telephone program compared to the face-to-face program increases the risk of non-completion, whereas being enrolled in a telehealth program decreases the risk. Participants refer to better logistics, social support, better transition of care, and its integration with a person-centered approach as enabler factors to cardiac rehabilitation completion. These findings can be used to co-create and inform the development of programs that better match the needs of people living with socioeconomic disadvantages or living in rural and remote regions of Australia. Okay, so after those results, I'm going to share the main insights that we gained from this study. So first, living alone and having low social support were associated with higher risk of non-completion for cardiac rehabilitation. Participants in the qualitative study highlighted the need for social support for those living alone. Early identification of patients living alone and providing social support, including home visits, can increase the participation in cardiac rehabilitation. So poor transition of care from hospitals to the start of the cardiac rehabilitation, including long waiting times and lack of clear communication, contributed as well to patient lack of interest and non-completion of cardiac rehabilitation. So we need to improve the transition of care quality, reducing waiting times and enhancing communication. This can augment patient interest and participation in cardiac rehabilitation. Additionally, health literacy played a very important role in patients' perceptions of not being interested or seeing less value in the process of cardiac rehabilitation. So cardiac rehabilitation programs should consider a variety of approaches to meet the diverse health literacy requirements and provide sufficient information and support for patients. Lack of integration among multiple care providers during the cardiac rehabilitation process was something that was mentioned by participants, including the general practitioners, the GPs, affected patient engagement in the participation. So ensuring information, sharing information, more integration between the patients and outpatients cardiac rehabilitation programs and primary care providers such as the GP is crucial to increase patient confidence and participation in cardiac rehabilitation. Our findings highlight the importance of social support, a better transition of care, health literacy, care integration, telehealth, and personalization in enhancing cardiac rehabilitation participation and completion among individuals with low socioeconomic status living in rural areas of Australia. Thank you so much for paying attention to our study and our results. I am presenting today about CROW, what we call cardiac rehabilitation for all. This work was led and is led by Dr. Aline Belegoli, and it was co-developed by a big team.
There.
So, as she needs no introduction, my final 7 minutes is to present to you the overview of our accreditation project, which was initiated by Michelle McKinnon during the process of our partnership engagement process. Michelle was saying that this was something that she had noticed was a gap in practice, and so we set out on a journey of accreditation in cardiac rehab. So the background is over the last 3 years, really. So what our baseline was that there wasn't then, and there still isn't now, any accreditation process for cardiac rehab in Australia. And there isn't either a credentialing process, which is, we've separated accreditation for services and credentialing for the providers. There is, most of the South Australian cardiac rehab providers have been off to the Heart Centre in Melbourne to do a specific cardiac rehab program. At minimal, most of the nurses have a cardiac training background, but the qualifications and skills are really unknown in the workforce at this stage. By 2022, we didn't have QIs either, quality indicators, in spite of the fact there had been quite a lot of work done with standardization of the programs, like the 10-module program that was produced by the Heart Foundation. In 2022, the 10 Australian quality indicators were produced. I thought that was on the slide. Nope. But you have seen those before. Unfortunately, only 2 of those quality indicators have benchmarks that can be measured. That is waiting time and time to referral. So the rest were not really usable in an accreditation service. So we went on a journey, and we were working with an Australian provider of accreditation, and this was a group that was recommended by Rosie at the time. They actually accredited point-of-care testing providers. They turned out to be quite expensive as well. I think their charge per year for surveys on site was over $40,000. So we would have to do all the work to provide the survey questionnaires, etc., and the KPIs and the key performance indicators. So we moved on from there to established credentialing services, and there are 2 in the world at the moment: the ESC and the International Cardiac Group, Cardiac Rehabilitation Group. The ESC accreditation program is excellent. It's outstanding, and you can see on this slide the quality indicators there. They have clear benchmarks and goals for the services to achieve if you're delivering a quality service. There are some cultural issues, though, in the guidelines, ESC guidelines for cardiac rehab, and in these quality indicators, the Europeans are delivering 12 weeks of cardiac rehab with 3 sessions sessions per week, which is 36 sessions in total. That's the dose. They recommend in this benchmark that a patient should attend at least 24 to 36 sessions, and a lot of the research has been done on a dose around that area. Well, back in Australia, we have 8 as an average. 10 modules are proposed in the Heart Foundation standardised program. And as Lini showed, currently in South Australia, the dose ranges from 1, 4, 8 to 10. So we have variation in that area just alone. However, if we can prove, and I think CHAP is proving that this smaller dose actually is as effective, I think would be okay for international accreditation. So we did quite a number of meetings with the ESC. They were very keen because they wanted to accredit the whole of South Australia, all 23 services, except that it was going to be 5,000 euros per service for the accreditation. So it was very glam, bling, ritzy accreditation service. It would be great to have done it, but it was way beyond our budget, and there was some concern about achieving the benchmarks in our current state of service. So one of the most interesting things, Gemma was at ICCNet at the time, was that the Europeans had no established alternate mode of delivery except for face-to-face. So those 36 sessions were at the expectation of on-site or off-site delivery face-to-face. So they turned the tables on us and were very interested to learn more about the telephone service and the hybrid service and our web-based service. So we sort of spun it around there. So, well, you need to come and work with us to help us make these accreditation quality indicators suitable for multiple modes of delivery. So CHAP and Australia were influencing as an outcome of that interaction. So we found ICCPR, the International Cardiac Rehab Association. I've put perfect match there. In fact, Robin Gallagher from University of Sydney, who is the former president of the Australian Cardiac Rehab Association, is the current president of ICCPR. So we have a very strong Australian connection there. Also, Emma Thompson, one of PhD cardiac rehab researcher, is on their accreditation registry committee. So we're building stronger links between Australia and this. ICCPR is based in Canada with a former president before Robin Gallagher, Sherry Grace, and Sherry Grace is on our team, international advocate for cardiac rehab, especially for women. So she's been working closely with our crew team on that. So we have been looking closely at ICCPR as a potential way to accredit and credential South Australian cardiac rehab. So we started with our data because they have an established registry. And in fact, Alini's used the registry because she's been to the training. And what will amaze and excite our cardiac rehab clinicians is as soon as you enter a patient, you immediately get a service report back to tell you how that patient's meeting the current quality indicators and how your service benchmark is adjusted according to that patient. So instant reporting is but a dream of cardiac rehab in our state and our country at the moment. But we have a dream, and so we will keep working towards that. So as we said earlier, as I said in the opening comments, we have Wendy here, who I attributed for being the leader of the establishment of the CATCH database. And what's happening with CATCH is that there are these teams, research teams basically, coming to CATCH intermittently at 2011, 15 and now 22 to do audits, but the reports that come out of CATCH have been reported to us by the clinicians as very hard to, they're CSV comma files in an Excel spreadsheet, and so you do need to hire a statistician to clean it up and sort it out, so we understand that. The other thing that we learned from the audit was that there's quite a lot of data missing, so that adherence and entry commitments seems to be wavering over time. That is interesting to see, because if you heard Katie's presentation, when patients enter data about themselves at pre-assessment, they were 100%. They entered 100% of their data, no data missing. And then at post, not as good, 50%, but still higher than clinician entry. So it's an issue that we've got. If waiting times, the Australian benchmark is 28 days, and the international benchmark is 14 to 28 days, and the statewide cardiac rehab waiting time is now 6 weeks. So we're a little bit over that. We also had good completion amongst those who were referred to cardiac rehab. So we have good completion rates. They actually stand up to the international and national benchmarks. But the ICCPR accreditation process is, as we have demonstrated today, a commitment to, involves consumers. So not only does the cardiac rehab service input data about the quality indicators, they also have a survey that's completed by the patient themselves. Do you understand your medications? Have you made lifestyle changes? So similar to the questions that we had in a conversation with Etta and Clayton today, so it's very different from what we experienced with the ESC. So what we're doing at the moment is we're going through this process of learning. We're looking at accreditation at the moment based on audit and what we need to know and how we need to prepare services as an education program. It's the final education program in CHAP. So we've been working closely with Sue and Michelle at Modbury, and we're taking them through the full process of accreditation in a pilot study. If anyone in South Australia achieves ICCPR accreditation, they will be the first in Australia to be internationally accredited or accredited at all. So it's a reasonable goal to set to achieve. It would be great to have the whole state internationally accredited. So what we're going to do is we've got a revision of the audit report, which is a simple black and white document which looks at all the KPIs that we measure, and we're going to match that with the ICCPR accreditation survey about the services. So there's 3 steps in the ICC process. There's an initial survey where you fill in a whole lot of data about your service and about the training of your team. The ICCPR accreditation standard requests that at least one person in your service has done the online training. So 2 people, one at Modbury and one at Noirs, and Alini in the room here, have all done the ICCPR training. It's 100 Canadian dollars or Nigerian shillings, not sure if that converts, but it's relatively cheap compared to the prices that we've seen. Even it's cheaper than going to Accra, actually. So you complete it online. Now, the feedback from the 2 participants, apart from Alini telling me that you practice entering the data into the registry and how amazing that experience was, the 2 participants who've done it at Modbury and Noirs have given, one was very senior, and she said it was still worthwhile because there was quite a lot of information that she was reminded of or that she actually picked up as new. The Modbury participant was a newbie in cardiac rehab and absolutely loved it, learned so much, so got very good feedback. It's online, it's in your own time, you take it in your own pace. And I think the Modbury participant was allowed to go off and have a coffee and do a couple of modules at a time. So we've had positive feedback from the ICCPR. So as I said, we're going to send out a copy of the first step credentialing. And then the final step in the 3 steps of credentialing is the on-site. Remember, I'm doing this because that's what accreditors do. They have a clipboard and they go around like this. That can be done virtually as well, but we now have several people in Australia who are eligible to do the accreditation, so they could come to your site. So step 1, fill in the survey. Step 2, get someone trained, at least one person trained in your organisation. Step 4, you need to fill in at least 100 patients, 60 patients over 4 months, that's what I'm trying to say, into their registry. And actually that includes the patient data collected from patients as well. So we're going to put that all out there and let people look at it in an educational experience and then get feedback on where we need to go for the next steps in raising the quality and standards to international and national standards for cardiac rehab. And so, yeah, that's a very positive future step for cardiac rehab standardization and improving data entry. So, question time, and then we're going to have final comments. And I'm in charge of questions. So my question to, was there any questions from the audience for starters? Sarah's here with the microphone. Yes, Han.
Now, I've got a question, whether it's to the four of you or the previous four, because it might be for Aline, is that thank you very much, everybody, for your presentations. They've been really, really interesting to listen to and to hear your outcomes. My question is, what, at the end of the day, landed up to be the referral rate into programs? Because I'm pretty sure it wasn't above 80%. I know what I think you said it was, but I just wanted to hear that again. And my question to anyone is how we basically improve the referral rate. Okay. Because until you can improve the referral rate, all of this good work obviously isn't wasted. That's a wrong word to use, but we need to get people into the programs. And I always had the assumption, clearly wrongly, that if you had a cardiac event, you were immediately referred to cardiac rehab. And I think many people outside of here would think that. So it staggered me what we're looking at numbers-wise.
Aline, and then me, and then Rhonda maybe. Would you like to make a comment, Rhonda, as from Rhonda point of view or from ACRA point of view? Yeah.
Hi, I'm Rhonda and I'm from Flinders Hospital, one of the cardiac rehab nurses. I job share with Sancha, who's not here today. I believe that with the referrals, I'm quite confused with why it's only showing such low numbers, because I do believe we screen every day, we look through all our data. I believe we're doing a good job of referring off, but I do know that our service is divided into heart failure as well. So heart failure, they're not doing the database, but they're definitely referring a whole heap of patients. They see hundreds and hundreds of patients, but they're not onto the catch data. So I'm just wondering if it's just not collected rather than not actually being referred.
So I'll add on to Rhonda. So Rhonda, is cardiac rehab referral a 24 hours, 7 day a week, 365 day a year service?
We're away for public holidays. If we're away for Christmas, we actually get the guys in coronary care to actually flick out lists for us, and we actually do go back and go through those lists as well. We do not, however, it depends on who you're actually capturing. We're not actually doing the TAVI patients, we're not doing the AF patients, just because of resources and not being able to capture everybody. So if you're including those as well, that would be a reason why we're not including them.
Leni.
Yeah, thank you for a question, Enrica. This is really important in the project. So the numbers from the audit from 2016 to 21 show 31.9% referral rates. And this is the inclusion criteria that we used was based on the guidelines that all kind of, not all kind, but a wide range of cardiovascular conditions. So not only ACS, so ACS, revascularization, arrhythmias, valve procedures, AF, they were all included in criteria. So when looking at this criteria, we have 31.9%. We do acknowledge that there are differences in South Australia regarding metro and rural in terms of what each of the regions call an eligible patient to cardiac rehab. And as I mentioned in the presentation, this is because there are other services in metro area that take care of this people with heart failure or with AF, arrhythmia, etc., but not for the country. So we raised this issue very early in the project with the coalition, because of course this is fundamental to all the referral rates that we are calculating. And the decision was, no, let's do the audit like this, and perhaps only a subgroup analysis on ACS, because we want to be evidence-based, so we want everyone to have the opportunity to go to cardiac rehab. But I agree with Rhonda, there is a difference in terms of the eligibility criteria. So this was for the audit, 2016 to 21, and then when we looked at the number of referrals in the CHAP from 2021 to 2022, we clearly see that most of the referrals in the CAT center referral system are for patients living in rural areas. So I think this is another issue that we need to investigate and highlight, is that perhaps the central referral system is also being more used by the rural services and not by the metropolitan services. And I think it's because of the internal referral that I mentioned. So if the patient is in RA, they perhaps get a direct referral to the RA cardiac rehabilitation program, so it doesn't go through the central referral system. And this is particularly, this is an issue because the CAT central referral system is the way the state is using to evaluate cardiac rehab. So if we don't have a central referral system or central database where we can see all the referral, this is problematic. We will never get to the correct numbers. So, yeah.
Is that something that's looking at some broader translation?
Yes. That's in our model. So there's a thing called direct referral at the moment, isn't there? If you're at Flinders and you're seeing a Flinders patient, bang, you're in. But we're not recording that. So that's, that it's not. We know our awesome clinicians are doing a great job. We just haven't got the data to back it at this stage.
Yeah, but what I was sort of suggesting there is when you're looking for the wider translation and perhaps with the involvement of the statewide clinical network, et cetera, is that there is something that lands up. I mean, I think it should be mandated that everybody is referred to the central referral unit now.
Yes.
I know that's, there's resources associated with that and so on. But from everything you've said is that you can't really change, you're not going to be able to change this significantly until that happens.
Yes, we 100% agree, and that will be your recommendation. So now we're going to one quick.
Just in terms of the why potentially country patients are ending up in the CATCH database, is we do use DRG codes for patients who are not necessarily referred by clinicians. So they're automatically sent in a last report, which we then triage by the central referral service. So country patients who aren't getting clinician referrals, we're still capturing, but those DRG codes we're not getting for metro patients. So that could be maybe one reason.
Fantastic. Problems solving, that's really good. Now we're going to transition to the final session for this afternoon. So we'll ask Clayton and Ella to come back on Etta to come back on screen, Wendy and Alini to come back on stage, and I'd like to introduce our facilitator to welcome back to the stage Norma, please.
Thank you, everyone. I'll try to pull an Oprah move, so hope I succeed. Anyway, thank you so much for staying with us up to this point, and thank you, my panelists, this afternoon. It's a bittersweet moment because CHAP is coming to an end. Sweet because of all the achievements, bitter because we are going to move on to other projects, but that's expected in research anyway. but we hope we'll transfer the goodness we've got from CHAP to all these projects we are moving to. So we just want you to share lessons learned and nuggets of wisdom for the next stage. So I'll start with you, Robin. Apart from not starting a project during a pandemic, what's the most important lesson you have learned from CHAP project?
Well, you've heard a lot of accolades about our team and how we feel about each other working together, but actually the lesson I learned is the value of our clinicians. That's why we're here, as well as patients. But having, I remember Happy Wednesdays at ICCNet, we had this incredible partnership relationship at ICCNet with all of the clinicians there. I'm looking at Catherine and looking at Rhonda. You know, we were on the phone and we were on Skype for hours trying to relocate the Flinders Medical Centre cardiac rehab service up to the university gyms during the lockdown. That they'd been asked to clear out the gym and they set up PPE dressing rooms. So they were tough times. But through all of that, we've had these amazing relationships, and there's certain members of the country cardiac rehab clinical workforce like Carolyn Wilch and Frank that stand out amongst all of them, or in fact everybody, who have been genuinely happily engaged and involved in this. So the lessons I've learned is how valuable that is in a translation project. You can't buy it, and if you don't establish that sort of relationship, I don't think you could be successful. Yeah.
Good. We are grateful for the dynamic teams that we work with. Yeah. Thank you, Robin. And so I'll pose a similar question to Clayton, who is online. What lessons have clinicians taught you during the translation process of the CHAP project?
Well, the lessons they've taught me is to be a bit more open, to not be afraid to ask the dumb question, which I've done many a time, but it did take a while. And I guess it's coming down to having a bit of confidence and an ease to be able to ask that question. A group of people that helped me to do this, and I'll give them a big shout out now, is the nurses. I'm not going to mention which hospital I was at, because last time I did that and I mentioned the nurses, Robin got stuck into me and I thought a war was going to start. But the nurses, you do a fantastic job. But they being able to have that conversation with nurses, doctors, and just ask them the dumb question. Like when I said to my cardiologist, I get this little twinge. Do I need to worry about that? I mean, what's going on? And he just said, well, that's just part of life. You're going to get them now. And just accepting that, okay, it's us. I didn't think I could ask him that. And because I knew if I asked Etta about it, we'd be straight to the emergency room. So I can ask the cardiologist. And I think that was just important to understand that. But I know from being at our rehab group that we went to a couple of weeks ago, some of the guys in that group, and the girls there too, they're not at that point where they feel they can ask those questions. So somehow we've got to break that barrier down to make it easier to ask the dumb question.
Great, thank you, Clayton. And just as a reassurance, even clinical people, when we are patients, when we're on the other side, we're also scared of asking dumb questions. So it's encouraging that there are no dumb questions. And it's good that you've had that big takeaway from the CHAP project. So we'll move on to Aline. What lessons have you learned from consumers during the co-design process of CHAP and now with Kruth?
No. First of all, it was a very satisfying process to be part of. And I think I can remember a quote very clearly in my head from a patient in Waiala, one workshop participant, and we were asking him, oh, how would you like the language to be, or the website to be? And he said, just make it idiot proof. So it's kind of related to what Clayton was just saying. So there are no dumb questions. Make it simple to the patient. Use an appropriate language, and don't try to be fancy in your website or in the service that you are providing. Try to be useful and get to know the patients, or especially in terms of health literacy, what health literacy levels your patients have, and speak to that level. Don't go beyond and try to be fancy or not. This is not the point.
Great, thank you, Aline. Aren't we all academics guilty of fancy language? That's a big takeaway for me. So I'll continue on to Wendy now. What advice would you give to another research team based on the lessons we've learned from the CHAP project about implementation?
Yeah, it's a great question. Thank you. Look, I think the team, Robin, her leadership, and everyone who's been involved have done lots of things right. You know, obviously, when you think about building on evidence, making sure you've got everyone involved at the start, having a good game plan, knowing the impact you're wanting to get. So there's many pieces of the puzzle of how you translate research into practice that are there. I think the thing that needs to still happen, and I haven't been here all day, but listening to it, and I know Rob and I have this conversation regularly, and it actually builds on Hendrika's question. How do we actually change the system to accommodate the findings that have actually been established? What is that piece, and who does that? You know, I don't see too many policymakers in this room. I don't see some of the decision makers, and that's not easy to do, and it's not a criticism. I'm like, okay, so how do we do that? We do have a good group from the Heart Foundation. They're a strong advocacy body. So how do we actually take this knowledge and have the 10 top things we need to deliver in this state to actually make a difference? I feel like I've been on this same journey for a very long time, but we're still there. But we do have the clinical network. You know, there's things. So how do we pass this to the next people? Keep the expertise and your amazing leadership, Rob. How do we pass it so the findings don't just sit in a drawer? I don't think they will. I think there's many things that will remain. Listen to, you know, the service that's being run for a start, that's going to continue. That's amazing. How do we actually not lose any of it? No, that's a bit of a golden dream, but I do think we need to think carefully about the things. Now, we're at a cardiac meeting not too long ago, and we were actually brainstorming about what that advocacy agenda looks like. I think we need to go back there and actually think very carefully about the key deliverables that are actually going to make a big difference, building on this amazing work. But yeah, in answer to your question, telling another team, I'd say have a look at the model. In fact, I've got Robin in to help me on another project. So look at the model, look where it's going, and then don't forget that it's really hard to get these things into practice, even if you do amazing work.
Wow, thank you. That's both a recommendation and a big challenge for us. Yeah, and now finally for Etta, how has your life changed because of that CHAP project?
More empathy probably would be the main one. You never know what another person is going through. It's made me more aware of asking people how they are rather than just going, "G'day, how are you?" And listening to what they're not saying. It's also made us aware of diet, exercise, networking when you feel overcome with anxieties about stuff, reaching out to people, not keeping it just between Clayton and I, and just trying to get a balance where, yep, things can go pear-shaped, but we've been through the worst. So it's not as bad as it was last time. What's next? So it's just a matter of moving forward and keeping positive and not dwelling on what could have happened.
Great, thank you, Etta. I guess we've all learned bits and pieces of what you've said from you as our consumers as well. And now I'll ask Wendy for some final remarks.
Yeah, just a quick comment. Just to say that Health Translation SA has been really pleased to be looking at how this project has brought the academic rigour and the vision of academia together with health services, and that's really what we're on about, trying to work out what is the problem, how do you bring it together, and I think they've done an amazing job at doing that. To that end, one of the outcomes from my perspective is we're going to do an impact story on this, and hopefully that will capture, along with your amazing report, highlight some of the other outcomes that, or some of the impacts that, in a way that we can project. So congratulations and thank you for being part of Health Translation SA.
Thank you so much. And let's thank my panel. Thank you. And there'll be an evaluation on my opera impression, all right?
So several times this afternoon we've had the what's next question. So I think it's really important that we close on leaving you with that information and those highlights. I'd like to, we truly have had the opportunity to acknowledge the amazing team, but I'd also like to add to that, and of course Etta and Clayton and our clinicians, but I'd like to make a special acknowledgement to Rosie and Phil Titterman. I am an agent fulfilling Phil Titterman's vision, which Rosie was a key agent for earlier. Rosie and I were great partners in getting this grant together, and it was a huge achievement when we did it. Don't get me wrong, we were pretty happy. We were down at that Spanish restaurant on Unley Road with Phil having a drink afterwards, so we were really, really excited about. And there was a time just recently when I stopped and thought, I'm going to do this for Phil, that all of my motivation and leadership in achieving these outcomes is really driven by helping to achieve Phil's vision. So I just wanted to say those few words about Phil and Rosie and the origins of ICCNet. A few Christmases ago, about 2010 it was, Phil had taken us to Christmas lunch in a nice bus down to McLaren Vale. It was fantastic. Thanks, Phil, he shouted. Not one person in that bus had a job at the end of that week. That was before ICCNet was a permanent service. And so that was how we were rolling in those days. And now look at all the amazing work and services and benefits that country people are receiving thanks to the ICCNet vision. We still will be going on. Crawl, the Cardiac Rehab for All project will finish on the 31st of January, just a write-up of the papers of the consumer engagement and thematic analysis, etc. So that will be another outcome still to come. The Crude project is going until the 31st of May. We've just in the process of finishing the changes to the website with the special modules for women, and we've done some really nice upgrades to the whole website overall. And we will recruit as many women as we can from our packages and our postcards with My Heart, My Life and going to the referral service. And we will evaluate the impact of the project on outcomes with women. As I said early at the governance meeting, the ultimate outcome for a translation project is to become part of policy for practice. And so the greatest thrill of all was when Jamie Bennett from the South Australian Cardiac Rehab Clinical Network called us and said, well, how hard would it be to get this CHAP model into care across the state? Of course, we said easy, but clearly you know that's not quite true. But we are working, they have appointed a cardiac rehab project manager in the clinical network. She's in the process of gathering baseline information, and we've had a couple of meetings with her already, but she has asked us for a copy of this, which is the adaptation of the statewide clinical network adaptation of CHAP, and it really encompasses absolutely everything that we've been talking about today. The central referral service, a bridge while you're in waiting. If we can't fix the waiting time, we could at least have people doing the web and My Heart, My Life online, and all of the new fantastic resources available from the Heart Foundation. And then every person in South Australia will have the opportunity to have their cardiac rehab their way when it's appropriate and convenient for them. So phone with your GP, on the web, or a lovely face-to-face program. And then, of course, we've got the Heart Health for Life concept, where we'll have very clear, strong links into general practice, Heart Health for Life, integrated to care, and we'll continue the data collection as we talked about earlier for 6 and 12 months follow-up. So there is our dream. It's going to go into practice. We've carefully thought through it all. But most important, it's evidence-based, and we've got quality indicators, and we've got current benchmarks now to back everything that we're saying in that model. So ta-da, there it is. So thanks to the CHAP project team for standardising measurable quality in cardiac rehabilitation programs, including the how and the where it should be delivered. And Phil Titterman has said at every presentation that he's spoken at with us that he acknowledges that this, it's called the nexus in my department at the university, the relationship between academic and clinical research. He would never have it happened if this was a project run by, no offence, a health department. And the fact that we had achieved so many outcomes, so many career achievements, was because we are this nexus between the clinical and academic. So I think we're actually going to demonstrate this again, and I think that's why Nalan has approached me and our team for the Safe and Hope project, is that they could clearly see, they go, we want this, we want what you've done here in CHAP. So thanks Phil, thanks team, thanks everyone who's been involved. We've got a few things to do to get us over the edge, but as you can see, it's been a blast. And we have had a bit of fun along the way. So thank you very much. That's in the photos. That's the fun bit. Thank you.